Hello, everyone, and welcome to the TrialSite News podcast called Farrago. I'm Erin, your host, and thank you for joining in. Today, we will be chatting with Dr. Thomas Althaus about a study titled, How Effective is the mRNA Vaccine, Pfizer's vaccine, their version in particular, against SARS-CoV-2, COVID, transmission and infection, a national program analysis in Monaco, July 2021 through September 2022. This was published in BMC Medicine, which is a peer-reviewed and open access medical journal, in June of 2024. So thank you, Dr. Althaus, for being here. We really appreciate it. Welcome to the TrialSite community. We're all excited to hear from you. But first, do you mind sharing with our viewers a little bit about yourself and the work you do?
Well, thank you for welcoming me. I'm a public health doctor specialized in infectious diseases. My background is mostly in infectious disease wards in hospitals in Paris. And I'm also a PhD from Oxford University. I mostly did it in Southeast Asia, working on causes of fever in primary care. So my interest points towards infectious diseases, how to fight them, and how treatment, vaccine can actually play their role to be the most effective.
All right. So you were a little busy during COVID, I would imagine.
I actually came to Monaco. I was appointed in Monaco because of the COVID crisis. The government was looking for an epidemiologist in order to organize the vaccination campaign. And therefore, I've been asked to join the team here in Monaco for the public health service. And this is what I've been doing over the past years. And I'm really grateful about the impact of the work we've been doing here all together in this very small country, but quite importantly positioned between Italy and France.
All right. Well, we are excited to hear about this study. So in the study, you looked at SARS-CoV-2 dynamics in various community settings, household, occupation, and schools to assess both the direct and the indirect effects of Pfizer's mRNA vaccine in Monaco for different COVID variants or variants of concern. Can you first briefly summarize how you conducted the study?
Well, this is the most beautiful part of that study, is that initially it was not a study. It was a governmental program meant to identify all potential contacts of a confirmed case and to investigate whether these contacts in every setting you mentioned potentially was carrying COVID. We know that lots of COVID cases were asymptomatic, so without any symptoms. And the trick was to identify those who were carrying it without being tested. And the role of that program was to make sure that each and every contact could be tested. And this is, I think, one of the most unique programs in the world, knowing that you have to imagine a whole bunch of people in a room on their phone trying to track every contact and to inform them about the necessity, the need to be tested, and then to follow them up to make sure that we could collect the results of their tests. And this is, I think, a very painful and difficult method, but at the same time, it was the only way we found to control the circulation of the virus, and therefore we were able to maintain a certain degree of life and social interactions while most countries were actually under lockdowns. So that's, I think, was the special input and special parts of that study, that it relied on a very unique and ambitious program.
And can you tell us a little bit about the demographics of Monaco, or the population you were looking at, to give our listeners an idea?
Well, it's quite comparable to Italy and France. The median age is around 45. The gender distribution is roughly the same than France and Italy. We do not differ in terms of demographics comparing to these two neighbors.
So pretty similar to your neighbors.
Absolutely.
Okay, so you were identifying index cases and contacts. Can you tell us how you defined an index case and then how you defined a contact?
Well, we relied on international standards. The diagnosis of SARS-CoV-2 was implemented through RT-PCR that was automatically registered within our national data set. We also offered access to a rapid antigen test in pharmacies, and those tests were obviously labeled with the confirmed European Union reinforcement label, and that is it. So PCR mostly and rapid antigen tests in pharmacies. So we had these two ways of diagnosing SARS-CoV-2. I think the next part of your question was about contacts.
Yes.
Well, contact was the definition of contact is actually quite usual and simple. It's anyone in contact, professionally, household, school, wherever, anyone in contact with a confirmed case, as I said, either confirmed with PCR or with rapid antigen tests.
Okay. And we're going to talk about the secondary attack rate, but first, can we just define that for our listeners so they know what that is when you're talking about it?
The secondary attack rate is a way to understand how intensely the virus is spreading towards contact. If one person is contaminated, how good is the virus to spread and to contaminate the contact? That's how I would try to define it.
Okay. I think everybody kind of has a general idea now, which ties into my next question. From your study, it shows that households had the highest secondary attack rate, correct? Okay.
Right.
Can you tell us more about that result and any noted differences by vaccination status?
Well, I think we all had someone around us being infected while being vaccinated. And Monaco wasn't different from other countries. We rapidly noticed that vaccine could indeed help to limit severe forms of COVID and limit mortality. However, we rapidly noticed that vaccinated individuals would actually be infected as much as unvaccinated. And that was just an impression. We had to objectivize and to quantify whether this impression was correct or not. And as you say, we measured a very high transmission within households. And this is likely because our investigations were extremely extended, and also because Monaco is the most densely country in the world. So you can imagine how fast the virus can circulate.
And the secondary attack rate between unvaccinated and vaccinated contacts decreased along with variant emergence. Is that okay?
That is correct. That is correct. We noticed a slow regression, slow decrease of the capacity of the vaccine to stop the virus from spreading alongside variant emergence. And this makes complete sense. This vaccine, the original monovalent mRNA vaccine, was made from the Wuhan, the original strain, and the mutation and the mutations, I should use the plural, that occurred alongside time was a sweet escape of the virus from the vaccine.
And just before we move on, can you tell our listeners how you defined fully vaccinated for the purposes of this study?
Well, this is a very important question you're raising here. Uh, in France, as well as in Monaco, fully vaccinated individuals corresponded to different schemes of vaccination. And our study showed that fully vaccinated individuals with 2 doses had different protection than those with a previous infection plus 1 dose of vaccine. So it seems that being fully vaccinated with only vaccine is not exactly the same than being fully vaccinated with only 1 dose of vaccine plus 1 documented infection. And if I may add, the reason for that is quite simple. Being infected stimulates an immunity of the mucosal parts, of the upper respiratory parts of the body, which probably stops the virus from entering the body, while vaccination stimulates systemic immunity in blood. And of course, the respiratory sphere is not contaminated, is not exposed to the antigen injected in blood by the vaccine. And this is probably the reason why we noticed a difference between fully vaccinated 1 dose plus previous infection versus fully vaccinated 2 or 3 doses of vaccine only.
Right. And that was what we called the 2 doses and then plus a booster. Okay.
Correct.
So let's chat about vaccine effectiveness against infection for the households. What did you find there?
Well, the story is quite beautiful because the princely government of Monaco invested in this program. So we had lots of data, but we were quite unable to analyze them because it was just too much. Monaco is a small country. We don't have the capacity to run and to carry out complex statistical analysis ourselves. And so we actually benefited from the WHO, the World Health Organization, help, especially the European agency from the WHO. These people were amazing in a way that they helped us to clean our data, to make sure that the analysis we were running would be, in terms of methodology, robust, transparent, with results we could really rely on without any doubt.
So there was a statistically significant protection during Delta and the first Omicron wave for both
Right.
index and contact cases. Okay.
The protection so there are two comments. The first one is that yes, there was a significant protection of the vaccine against infection from the contacts, but the protection for transmission, so as an index case to transmit the virus, we noticed that the vaccine effectiveness was already much lower compared to infection, which means that infected people could almost transmit as much virus regardless whether they were vaccinated or not. But this difference between contact and cases disappeared when the BA4 and 5 subvariants emerged, and that was in, let's say, March 2022.
So what you're saying is, just to clarify for our viewers here, the vaccine effectiveness against transmission was not statistically significant during the Omicron BA4 and 5, which was the later Omicron wave. Is that correct?
Nothing was significant during the Omicron BA4 and 5. Nothing.
Okay.
You could be a contact. You could be a case. Vaccine had literally no effect on virus transmission or infection during BA4 and 5.
Okay, but you did find that it was significant during the early Omicron, BA.1 and 2. Now, did I also read that you didn't find a statistically significant difference during the Delta wave?
We did find a certain degree of vaccine effectiveness during the Delta periods, but the vaccine effectiveness was only around 30%, 35%. And when you consider a vaccine, you're looking for at least 80% effectiveness, and that wasn't the case at all as soon as the Delta arrived. And so this is not to advocate against this vaccine, is just to make sure that evidence is very robust for the vaccine to stop severe forms, but it was already getting weaker and weaker to stop the virus from circulating.
So with the percentage from your paper, vaccine effectiveness against infection was statistically significant but low, and you have your 32% during the Delta wave. But what does that, just to give people an idea, what does that translate to on a population level? Were people protected?
Well, yes, it provides a certain degree of protection, although it's disappointing. It's really low, but if you consider millions and hundreds of millions of individuals, it's still something. You can't just regard and look at it with a negative view. You just need to be very aware that you won't for sure be able to protect your family, and especially those with comorbidities, to be infected if you are, just because you're vaccinated. And I think we all had in our respective countries national campaigns promoting the vaccine to protect our relatives, and especially our weak relatives. When I use the adjective weak, I mean those with comorbidities, those who can develop a severe form of the disease. And I think this is to clarify that no, you don't protect your grandmother or your grandfather by being vaccinated during the Omicron wave. No, you actually protect yourself. And if you protect your grandfather or your grandmother, you do protect her or him, but you won't stop the virus from infecting them if you are vaccinated.
Okay, and I'm going to dig into that a little bit more when I ask you about future public health implications. I wanted to ask you about vaccine effectiveness. When you say the words low and high, and I'm sure this maybe depends on, what you're vaccinating against, but can you summarize that for us? What is considered low? What is considered a good response? Is there a threshold that everybody uses, or is it something else?
I'm not aware of any threshold. I only know that a vaccine with a minimum of 80% effectiveness is the one used by most international authorities. And again, this vaccine had an above 80% effectiveness against mortality, but not for transmission and infection. So because it was not corresponding and reaching the standards, we considered it low.
Okay, I just wanted to make sure our viewers had an idea of how you get those, whether it's low or high. So what do you think? Every study has limitations. Can you just tell our viewers some of the limitations they should consider?
Well, first of all, it's just one study in one country at one time point. And it's not because we found that our findings would have been similar in another European country or in the US or in Southeast Asia, Africa, or South America. So in science, you always need to collect and to gather evidence before generalizing your finding. It is very difficult to gather this evidence because it implies a lot of money, of investment, of human resources. And I think this is why our results are so special, and this is why we published somehow all data in such high level, high impact factor journal. It's because it's very difficult to publish those data. It's very difficult to collect them, to organize their collection. I'm not sure whether I answered your question, but I wanted at least to talk about that.
No, absolutely. I think you make great points there. I just wanted to give our viewers an idea of, what it goes into collecting the data and things that might work out or limit the study results and that kind of thing.
Oh, yeah. I mean, the paper obviously presents a few limitations. I'm not aware of any article without any limitations. And if the authors
Absolutely.
pretend they don't have, then it means you should be extremely worried and concerned.
Right.
So we do have lots of limitations, lots of missing data. But again, we benefited from the WHO Bureau of Europe help to make sure that the statistical analysis was as robust as possible. We adjusted by many factors. And I think the analysis is honest, transparent. We obviously leave the data sets in an open access so people can double check. It's really something we know it's a very sensitive topic, and we want to make sure that people can double check and ask questions about how we collected the data. And it's a national program, so there's nothing to hide.
When you say it's a sensitive topic, what do you think we should do moving forward to be able to have these types of conversations without people being labeled or, you obviously said it's a sensitive topic. I'm curious as to why you say that.
I have a good example regarding your question. There is a professor in Singapore named Lin Fa Wang. He's probably one of the most brilliant experts on SARS. He's been studying SARS forever, and he was advising many Asian, including Australian governments during the COVID crisis. And when people, he told me that anecdotes when we met in Singapore. He obviously had several questions about vaccination and who should be vaccinated and should we generalize vaccination and how good or bad is the vaccine and how should we use it and should we do lockdown again and again. And these experts actually confessed that it was all these questions were very difficult, that knowledge at that time was very scarce, and sometimes it was very difficult to obtain a strong, robust level of evidence. So I think the less we know and the more we tend to have robust point of view, unfortunately, and I think the lack of knowledge we faced at that time was a contributor for polarized perspectives and for strong points of view, while actually we should have been way more humble about everything we did not know at that time. But politically, maybe we need to ask ourselves, is it acceptable for a government to acknowledge that they don't know? I think it's very difficult to judge afterwards. But to me, the lack of knowledge was definitely a reason for such extreme points of view.
Based on your findings and being at the forefront of managing the pandemic response for Monaco, and from a public health standpoint, what would you say are the key takeaway points from your study?
First, for future public health campaigns, especially vaccination campaigns, let us be aware of the distinction between what the vaccine can do against SARS-CoV-2 and what it cannot do. And pretending that the vaccine can protect your family from being infected from you is not true anymore. And that should be clearly said, I think. We can't use the vaccine as a tool to stop the virus from circulating. However, we should use it to protect those who can develop severe forms. You know, the message I'm saying here has nothing special. It's exactly the same I would use for flu. We vaccinate individuals who are old or with comorbidities. Well, the same message would apply for COVID. So these would be the first most important messages I would like to people to keep in their mind.
What do you think the public health community can do better about communicating uncertainty?
The scientific community published a lot during the COVID pandemic. Many units across the world published, and the amount of papers published was insanely high. And of course, the higher the quantity, the more you ask yourself whether quality is also responding, because in an emergency state, we need rapid evidence, and sometimes it's difficult to provide quick, reactive, and high quality evidence. We provided in Monaco very good quality evidence, but with 2 years delay. So you see the difficulty of being useful and honest, and at the same time to react promptly and help government and stakeholders to make decisions.
Fair enough. Thank you so much for joining the podcast today and sharing this important study with us. Thank you to our viewers for joining in. Don't forget to check out the TrialSite News podcast on Rumble, which Brandon hosts, and also check out the TrialSite News website, which has a lot of opinion pieces as well as well-researched articles on the latest research and pharmaceutical breakthroughs. Thanks so much for joining from Monaco. Wish I was there.
With pleasure. Thank you again.
Absolutely.